aneurysms of the sinus of Valsalva. This is a kind of a localized weakness of the wall of a sinus of Valsalva, which leads to aneurysmal bulging, thinning just above the annulus at the leaflet hinge, and owing to the absence of normal elastic and muscular tissue, and even may rupture. Localized aneurysms are usually congenital, so there is a variant which may be congenital and present in very early age and relatively rare, which occurs to 0.1 to 3.5% of all congenital heart diseases. Demography, it is 5 times higher in Asians. So one of the theories goes that since the subpulmonary or doubly committed VSDs are very common in Southeast Asia and Pacific region, so one of the concerns is that with the RCC prolapse, the percentage of RSOV might be common in these countries. With the male predominance 4:1, average age of presentation is about 39 years, though it can vary as early as 18 to 19 years. Location, right coronary sinus is the commonest one to be rupturing, 65 to 86%. Non-coronary sinus is the next one at 10 to 30%, and left sinus is the least common with 2 to 5%. The rupture of a sinus valsalva to the RV is 60%, the commonest one. Right atrium 29%, left atrium 6%, LV is 4%, or even to the pericardium it has been reported lastly about 1%. The untreated rupture of sinus of Valsalva, average survival is 3.9 years after diagnosis. Mostly it acutely presents, though according to the book teaching, though we have seen some patients who have presented a little bit later on. So this is the classical diagram which we use for describing the sinuses. According to the CSICON and Kono classification, the type 1 is the right sinus of Valsalva, an existing tract of RV below the pulmonary valve. Type 2, right SV into the supraventricularis crest. Type 3A, right SV and RA. Type 3V, posterior zone of the right superior sinus of Valsalva and the RV. Right 3A plus V, right sinus and both RA and RV. And type 4, non-coronary sinus of Valsalva and the right atrium. So because the aortic root is central, the aneurysms can rupture into any of the cardiac chambers. Most common is the right sinus aneurysm into the right ventricle, particularly with outlet VSDs, the cause which I was describing. Next most frequent site of rupture is into the right atrium from an aneurysm in the non-coronary sinus. The usual age of rupture is adolescence or early adulthood, may lead to RVOT obstruction in some cases with the ruptured aneurysm. So the etiology may be acquired or congenital. Though in acquired one, lately it has been described that atherosclerosis or in Marfan syndromes, and in olden days it might have been syphilis. Endocarditis of aortic valve is one of the main causes, and congenital usually is localized. Associations, VSD is a very common association according with aortic regurgitation, coarctation of the aorta, atrial septal defect, tetralogy of Fallot, or even with the PDA. Presentation varies from asymptomatic murmur to a cardiogenic shock to sudden cardiac death. The first report was in 1839, and Walton Lehigh did the first successful surgical closure of sinus of Valsalva. Transcatheter technique for RSOV device closure was first described by Cullen et al. In 1994 with the Rashkin umbrella device. The paper was published in British Heart Journal in 1994. So the device selection. RSOVs are most commonly windsock-like with a broader aortic end which shoulders the device. Hence ADO, that is Amplatzer duct occluder, is the best suited for this defect. Although other Amplatzer devices like septal occluder and muscular VSD occluders as well as coils have been used in others. Techniques, most authors have described antegrade technique involving formation of arteriovenous loop, and a retrograde technique using muscular VSD device is also described, though it is slightly difficult to cross it retrogradely. Now in our study, the defects were closed from the venous side, that is an antegrade approach, and usually with the PDO, that is ADO device, 2 to 4 millimeters larger than the aortic end of the defect, as much as it would accommodate without disturbing the coronary anatomy and any other obstructions. We published this paper in Transcatheter Device Closure Rupture Sinus of Valsalva in Annals of Pediatric Cardiology. So pre-procedure assessment, the demographics, clinical assessment, echo for diagnosis and suitability for device closure. Associated lesions has to be ruled out. Mostly the most commonest ones are VSD and aortic regurgitation. We accepted mild aortic regurgitation, though anything more than mild we rejected the case and referred to surgery. In ventricular function, origin and exit of RSOV. TE for confirmation in certain cases, and hemodynamic study and angiography. So in our study, the defects were closed from the venous side. There is antegrade approach. Sorry, Transesophageal echocardiogram, origin and exit, The maximum diameter at the aortic end we usually take about 2 to 4 millimeters higher than that one. The length of the windsock, though in practicality it might not be that much relevant. The distance from the coronary ostia, which is a must, and the presence of AR on VSD and the ventricular function. So this is a still picture where the measurements have been taken of the aortic end. All these are still pictures intentionally used, and this was a picture where we have used the shown the windsock and the diameters. So the procedure first is consent. With the vascular access, we usually obtain the groin accesses and an arterial access on the left side just for the arterial monitoring post procedure. Heparin at 100 units, detailed TE and aortogram to evaluate the RSOV and aortic regurgitation and VSD, and LV angiogram to exclude VSD is a must. So the procedure done under TE and fluoroscopic guidance, check angiogram done to confirm the device position, device released, and angiogram after 10 minutes of release to see residual flow or AR, and post procedure we give aspirin for 6 months, antibiotic prophylaxis for 6 months. So this is one of the angiograms where the RSOV is opening into the right ventricular outflow tract. So this is the pictures where the arteriovenous loop is being formed with a 0.35 inch J-tip pneumo wire from the aortic side, snared from the venous side, and this is a device in situ before the release. The device is being released, and this is the post procedure angiogram whereby aortic regurgitation is almost minimal and there is no residual leak. So this is a similar one where the rupture is into the right atrium and which has been closed by a similar device. So the conclusion: favorable short-term and mid-term outcomes in terms of hospital stay, ICU stay, and on follow-up. Patients are spared from morbidity related to sternotomy and cardiopulmonary bypass. Transcatheter device closure of isolated RSOV is viable alternative to surgical repair. I would like to talk about the complications. I don't have the slide here. Complications are rare. Mostly the complications are that rupture or any injury to the aortic valve cusp causing more damage if the regulations are not followed. Residual aortic regurgitation, which might be more than mild at the end of the procedure if you have missed a VSD, and coronary artery damage or even coronary artery blockage post device closure if the device has been malpositioned or the device has been slipped away. Thank you very much.